Okay, so the first imbalance that we're going to talk about is an isotonic fluid volume deficit or hypovolemia. So the key here with this is that hypovolemia is isotonic in nature. It means that the um, osmolality of the serum is not changing. It also means that there is not a an electrolyte imbalance. And so that is the key to understanding the difference between an isotonic fluid volume deficit or hypovolemia and something like dehydration. Okay, so in dehydration, there is an electrolyte imbalance. In hypovolemia, it is a loss of water and electrolyte. So when we look at some of these risk factors, it's you just either like illness or injury when um, there is a decrease in both fluids and electrolytes from the body. So things like vomiting, diarrhea, diaphoresis, polyuria, fever, suctioning, abnormal drainage or wound losses. So something like a severe burn, not a small burn. You can also have where the person's just not intaking fluid and electrolytes. So, because they have anorexia or nausea or can't access fluids, so you may have somebody who's stranded somewhere and not able to intake fluids. They can't swallow, or they're very confused. They don't recognize that they're thirsty. So someone with dementia, or they're severely depressed and can't, get up, get out of bed and get those fluids. When we look at the clinical manifestation, so the person's going to feel weak and thirsty. There are different levels, and so we check weight because there are different levels of um, fluid volume deficit. And so we have mild, moderate, severe. We're going to see less intake than output. We're going to see the decreased skin turgor, dry mucous membranes, subnormal temperature, tachycardia, and a weakened pulse. A lot of these things you already know. If somebody has less volume in their blood pressure is going to be low. And what does the heart do in order to try to continue with perfusion? Well, it increases its rate. They're going to have postural or orthostatic hypotension. Their cap refill isn't going to be good. Central venous pressure is going to be down. They're getting um, a decrease in perfusion to the kidneys, so renal ischemia. So they're going to have less urine output. They are going to have an increase in the specific gravity of their urine. So the urine is going to be more concentrated because the body is trying to hold on to those fluids. An increase in hematocrit and an increase in the BUN. So remember that hematocrit is like a concentration of the blood. So does it make sense that the blood would be more concentrated and that there's going to be more waste products in the blood because we don't have as much fluid running through and helping keep the body flushed out. So some of those things that we want to make sure that we are doing is assessing for those manifestations. So monitoring those vital signs and temperature, skin turgor, eyes and O's, watching those laboratory findings that we just talked about. Then we administer oral and IV fluids as indicated. So it's always ideal to monitor oral or to administer oral fluids. IV, these would likely be isotonic in nature, and we'll talk more about those. Frequent mouth care because the mouth is dry. And we want to make sure that the skin's going to be dry as well, reduction in elasticity. And so we want to help prevent that skin breakdown as well as the safety of the patient who has that orthostatic hypotension. Another thing to note about um, isotonic fluid volume deficits is this can also happen. This can happen if someone is hemorrhaging. This can happen if someone has severe ascites. So ascites is a type of third spacing in which the fluid shifts from the vascular space into an area where it's not readily accessible as extracellular fluid. So ascites is when somebody has, liver, usually in liver failure. And so what happens is the peritoneal cavity fills up with fluids. It fills up, the person doesn't have as much albumin, or they start leaking albumin, and the water follows it. And so the water gets into the peritoneal cavity where it's not easily absorbed. And so they have that isotonic fluid volume deficit in that third spacing, and it takes much, much longer for it to be reabsorbed. So the tissues can slowly heal, potentially, and some of that can be reabsorbed. But what often ends up happening is that we actually have to go in from the outside. So they have to do like an abdominoparacentesis, where they actually go in and draw that fluid out of the peritoneal cavity, because there's not a good way for it to get reabsorbed. And obviously it puts pressure on the lungs and things as it continues to fill up. So just something to keep in mind is that 1 liter of water weighs about 2.2 pounds or a kilogram, and that weight changes of about a pound in fluid volume are about 500 milliliters. So just something to kind of keep in mind. Now the opposite is when somebody has fluid overload. And so we start to see fluid overload as as a lot of times a problem with breathing, because what happens is it will back up into the patient's lungs. The fluid can't continue to be pumped around like it should, and so the patient ends up with actual pulmonary edema. And so there's lots of different medications and nutritional therapy and things like that that take place when the patient has an isotonic fluid volume excess. So what we see here are the risk factors are excessive sodium containing IV fluids, or ingestion of sodium in the diet or medications, imbalanced fluid because they have heart failure, renal failure, or cirrhosis of the liver. So if somebody has all those fluids, or all that sodium, they start to hold on to fluids so that it's the same concentration there. So what we see in clinical manifestations, again, is weight gain. So it's very important to do our daily weights, just like it is when they have hypovolemia. When they have hypervolemia, we also need to watch their weights. Their intake is greater than their output. You have that full bounding pulse, but they're still tachycardic. They have an increase in blood pressure, distended neck veins. So even when they're, sitting up, that they start to get those moist crackles in their lungs, dyspnea, shortness of breath, and confusion, because now their lungs have fluid in them and they're not oxygenating like they should. So they don't get the perfusion to the brain. Nursing interventions, as we watch for those manifestations, we look at weight vital signs, watch for edema that will start to happen as well as the blood pressure is higher. And so the hydrostatic pressure will outweigh the colloid osmotic pressure, and therefore we get edema. We watch those breath sounds, we intake and output laboratory findings. We want to sit them up. We administer diuretics. So diuretics are going to be one of our most important medications for this population, because it will help to pull that fluid off of the lungs and let the patient be able to breathe better and get rid of the fluid. They may need to be on fluid restrictions and dietary restrictions, particularly sodium. And we want to, again, make sure that we are preventing skin breakdown. So I'll give you a moment to answer this question. Okay, and what would the answer to that would be is the presence of crackles in the lungs. So we have to be concerned about those crackles because they do indicate that the patient may not be, able to breathe as well. So we've spent some time talking about isotonic fluid volume deficit and excess. What I would actually recommend you to do is, before we move on to these electrolyte imbalances, I'm going to back up a little bit, is that you create a Venn diagram for these. And I'm going to recommend multiple Venn diagrams. I think it will help you in your studying though. So I would put hypervolemia on one side, hypovolemia on the other. You can put those things that you're monitoring for either in the middle, but then put those clinical manifestations and some of the treatments and some of the risk factors. So put some of those things in each of the, under the correct side. But what this will do is help you compare and contrast hyper and hypovolemia and what you see, and what you need to do no matter what type of fluid issue the patient is having, or fluid imbalance that the patient is having. Next, we're going to start getting into some of the electrolyte imbalances. And so I'm actually going to go ahead and take a break right here. And the next video will start up with electrolyte imbalances.